Good evening. I would like to invite Dr. Javin Jameria, Dr. Mukesh Jha, Dr. Pratik Rawal as a moderators, and Dr. Darshan Banker, Dr. Mihir Tanna, and Dr. Apurva Vasavada as a chairpersons. Please introduce our speakers. Please, Dr. Apurva or Dr. Banker, you can introduce the speakers. Respected.
Hi, I'm Dr. Mihir Tanna. If none of them are around, I'll get the session going. We are here to discuss a case of a 55-year-old male with a 99% calcified long LED lesion with a TIMI II flow, significant ECG changes, but negative biomarkers, but positive nuclear imaging scan. What would be the best strategy? The bout is between Dr. D.S. Gambhir, who will speak in favor of rotablation, old is gold, versus Dr. Prakashveer Parikh of Ahmedabad, who will speak on IVL as a game changer. We both know these two speakers very well. We have learned firsthand from these two speakers in our career. I welcome Dr. D.S. Gambhir sir to first talk on rotablation, old is gold.
Yeah, first of all, I'd like to thank Dr. Kamal Sharma for inviting me to his presentation again in the CardioCon. As you know, before 3 years, I spoke on the same topic, the rotablation, old is gold. But now 3 years have passed, and now we have new technology, with the intravascular lithotripsy, which is a very exciting and revolutionary technology. So I'll discuss this technology. As you know, the calcified lesion. Okay, so the calcified lesions, the lesion preparation is the key to PCI success. Despite having several calcium modification devices, including balloon-based techniques and atherectomy techniques, PCI results still continue to remain suboptimal with inferior long-term outcome in calcified lesions. I think this is mainly because it's the inability to treat the deep calcium and eccentric calcium with the currently available devices, except IVL. And the previous, all the devices which are excellent atherectomy devices, but they have higher procedure complication rate. As you know, the mechanism of action of calcium modification devices, there are only two ways to treat calcified lesion. The first is creating cracks, and second is volume reduction. Creating cracks, the best devices are cutting balloon and IVL. And for volume reduction, we have rotational atherectomy and orbital atherectomy. So when you select the calcium modification devices, the three important aspects are device crossing, is the ability to create cracks in the calcified lesion, and the ability to ablate the calcium. Can you see my next slide now, rotational atherectomy?
No, sir.
I don't know what is the problem. I don't know.
Now we can.
So rotational atherectomy is an excellent device because it creates massive cracks towards the wire base side. It definitely ablates the calcium and makes the calcium thin. It's got an excellent crossability. Can you see my next slide?
Yes, sir.
Okay. But however, as you know, the rotational atherectomy is a complex procedure. It is a hard learning curve. It needs special training and expertise. And effectiveness and safety are technique dependent. Often requires larger gynae catheter, particularly if you need a bigger burr. Rotawire is not suitable for direct wiring in calcified tortuous lesions. So you have to use the conventional wire and exchange with the microcatheter. And of course, when you're treating important bifurcation lesion, you are unable to protect the side branch with a second wire when you are using rotablation. In addition, there are special complications which are unique to rota procedure, like entrapment of burr, severe distal embolization leading to no flow, slow flow, and periprocedural MI, perforation, especially in tortuous anatomy, bradyarrhythmias, particularly when you are treating dominant RCA or dominant circumflex, and which may require prophylactic temporary pacing. Often, sometimes the rota procedure itself can lead to wire fracture of rotawire. And this risk is particularly increased in special clinical scenarios like thrombotic lesions in ACS. If the patient has dissected arteries, patient who have low ejection fraction, and we are doing intervention on the last remaining artery. In addition, rota is not always effective. As you know, the rota ablation is contact dependent, and ablation is highly influenced by the wire bias because rota works on the wire. So in patients who have eccentric lesion with unfavorable wire bias, rota is not likely to work. In addition, it is less effective in modifying calcium in large arteries with relatively large lumen. And it can ablate only superficial calcium, and deep calcification modification remains very limited. So the major drawbacks of rotational atherectomy are, despite being a very efficient device, the procedure itself is a very complex, not amenable to all the interventional cardiologists. It is associated with a life-threatening complication in a small number of patients. It is not consistently effective, and it has got several relative and absolute contraindications. So there is an unmet need for effective, safe, and operator-friendly device for preparing calcified lesions and improve clinical outcomes. Now, shockwave intravascular lithotripsy is a new vessel preparation technique for calcified lesions. It has got a unique, interesting mechanism of action. It has been developed based on the principles of kidney stone treatment, in which it has been used for more than 30 years. And based on the same principle, now the IVL has been developed to treat the coronary calcium. Basically, the device has three components: generator, connector, and catheter. Generator is compact, rechargeable, and via connector, it delivers electrical energy to the IVL catheter, which has got two emitters. And this catheter is like a routine conventional angioplasty balloon, the monolayer balloon. It can be advanced over any 014 wire using standard PCI techniques, and it can deliver up to 80 lithotripsy pulses. It has got unique mechanism of action. The balloon emitters receive electrical pulses from the generator, and that electrical charge will vaporize the fluid and it creates the rapidly expanding coalescing bubbles, which generates the sonic pressure waves. And these pressure waves are unfocused, and they deliver circumferential pulsatile mechanical energy into vessel wall with the equivalent of almost 50 atmosphere pressure. And it interacts with the high density calcified tissue. It doesn't affect the soft tissue, doesn't damage the soft tissue, and it creates the multiple micro and macro fractures in the calcified plaque, which improves the vessel compliance, and thereby it helps in expanding the vessel and the stent. It is a very simple device to use. No special training or experience required. It's 6-friend guiding catheter and as well as 6-friend guide extension device compatible. No special guide wire required. It can be performed. The procedure with IVL can be performed on a workhorse wire. And you must be wondering why the IVL is so effective. I think because it's the best device to create fractures in calcified lesion. It creates multiplane, circumferential, longitudinal, and then sometimes even transmural fractures across the calcified plaque. And as you know, the higher the number of cracks, better is the vessel compliance. So by modifying superficial and deep calcium, it definitely helps to open up the calcified lesion. And there is no issue of wire bias because the balloon inflation eliminates the wire bias, and it provides a circumferential calcium modification. As compared to rotablator, it provides calcium modification only where the burr touches the arterial wall or calcified plaque. It doesn't ablate the opposite wall calcium. So IVL is a king of tracking devices. Is effective across the calcium spectrum, whether superficial or deep, concentric or eccentric. Even it can crack the calcium behind the stent, previously deployed stent, either acutely deployed or chronically deployed stent. It also helps to treat the nodular calcification also. And most importantly, is not influenced by the wire bias. So IVL is a one-stop solution for all you need to treat the calcium. And then why IVL is very safe? It is simple, effective, it is safe. Why safe? Because it is based on the very important concept. Because it is the wave, sound waves, and not the balloon, which creates the disruptive force. It modifies the calcium not by balloon inflation, but by sound waves. Because balloon is inflated only at 4 atmosphere pressure. So because there is low pressure balloon inflation, it reduces the risk of barotrauma, dissection, and perforation. And it's a differential disruption. It doesn't affect the soft tissue. It is hard on hard and soft on soft. So it's very safe. And the calcium fragments which are generated by the IVL, they remain in the vessel wall. So there is no risk of distal embolism and no slow flow, no periprocessal MI. So I will got exceptional safety. There is no risk of bradyarrhythmias, so no need for temporary pacing, no additional need for mechanical support devices in patients who have low ejection fraction because there is no risk of distal embolism and no reflow. And IVL is safe to use in different clinical scenarios like low ejection fraction. Even with the bifurcation lesion, you can keep the wire in the sideband because it doesn't interact with the side branch wire. You can perform intervention safely in the last remaining vessel. Even in target vessel which supplies corridors to other reported arteries, IVL is safe. You can use IVL if required in calcified lesions, during STEMI, during LMCA procedures, even in tortuous arteries and long lesions because there is no risk of perforation. These are all theoretical discussions, but I will show the data also. It has been, this is the safety and effectiveness data of IVL across the disrupt CAD studies. As you can see, the 30 days MACE is very low, around 5 to 7% in heavily calcified lesions. And procedure success rate was more than 90% in these complex patients. And as you can see, complication rate is very, very low. There is 0% incidence of no reflow, 0% incidence of slow flow, abdominal close is extremely rare, perforation is extremely rare, no flow limiting dissection is extremely rare. So basically any angiographic complication using the IVL is extremely rare. So it's a very, very safe device, an effective device. And the data from disrupt CAD 4, 1 to 4 OCD sub-studies. There is some controversy regarding whether IVL is effective in the external lesion like calcified lesion. As you can see in this slide, despite the difference in the calcific arc, less than 180, 180 to 20, or more than 360 or 360 arc, IVL achieves the similar MSA across this different calcium arc, and stand expansion also similar, despite similar even in concentric as well as in the eccentric lesions. And IVL can be used at all stages of PCI. You can use it upfront, or you can use a secondary when you fail with the other devices like high pressure balloon devices or rotablation. If you fail rotablation, you can IVL even if artery is dissected. You can use IVL even if you have by mistake by under preparing the vessel, you deploy the stand and the stand is under expanded. Still, you can use IVL to expand the stand completely. And patients who come with the late restenosis because of underlying stent under expansion because of calcified plaque, even this chronic stent also IVL can be successfully used to expand the stent completely. So in short, the IVL is a revolutionary technology. It's simple to use, very safe, highly effective, and widely applicable in different subsets of lesions and clinical scenarios like bifurcation, thrombus, dissection, tortuous lesions, ACS, low EF, LMCA. It can be used primary, secondary, or tertiary also.
Sir, please wind up. Time is up.
Okay, thank you. This is my last slide. Okay.
So do we have Dr. Gambhir? He is able to join now. Dr. Gambhir, over to you. Your session, please, sir. So please share your slides.